Hi, this is Nicole Kopchick, and welcome to Back to the Basics, Caring for the Critically Ill. In this episode, number 6, we are going to chat about arterial lines. Specifically, we're going to talk about the basics for caring of patients with art lines, setup and supplies that would be needed, the dynamic response or fast flush test to know whether you can trust your line, and then finally just some general monitoring tidbits about arterial lines. So let's get started. So just a reminder of our patient. We had a 42-year-old who has progressive shortness of breath. Now, this is the 6th episode, which we're carrying through for her. She was intubated, mechanically ventilated. She's on propofol, getting fentanyl PRN, and she's got severe ARDS as defined by the Berlin criteria. She was just placed in the prone position, and we suspect she's got some sort of a viral infection, either from COVID-19 or influenza. So this was her x-ray, again, confirming bilateral pulmonary infiltrates. And then these were her last vital signs. So looking pretty good. Her heart rate's come down a bit. Blood pressure's pretty stable. She's breathing at 20 right with the vent. Her temp, finally her fever broke. Her temp is 37.8. And then her SpO2 is now up to 96% after we prone her. So what comes next? Well, let me just remind you of her vent setting. So she's on assist control mode, which is a volume mode of ventilation, pretty commonly used. She's on 5 mils per kilo of tidal volume, so that's per her predicted body weight, which gives her a volume of 274 mLs in and out of her lungs with each breath. She's at a set rate of 20. She's on 16 of PEEP, which is a decent amount of PEEP, but we still do have some room to go if we need to. And she's on 100% FiO2. We got a gas about an hour after placing her prone, and she's still got a respiratory acidosis. You can see her CO2 is 59 with a pH of 731. Her PO2 is 156, bicarb is 28, and her saturation is 96%. So, based on this, we really honestly could come down on her FiO2. I really am hesitant to come down on the PEEP just because I want to use PEEP as a stent to keep her distal airways open. But I honestly think we can come down on the FiO2 just a bit. Her P to F ratio is 156. And in the setting of ARDS, I mean, that's definitely right at severe ARDS, but she's looking so much better. Her peak inspiratory pressure is 34. Her plateau pressure has come down to 29, so that looks pretty great. And just remember, plateau pressure. You do an inspiratory hold on the ventilator. The patient takes a breath in. At the point where there's no air exchange taking place, you get the pressure at that point. Ideally, we want that less than 30. And then her driving pressure is also much better, so it's down to 13 now. And ideally, we want that less than 15. And her compliance is up to 21, so everything's honestly looking quite a bit better for her. So next steps, we decided to kind of hold them and let her be, but we made a decision to put in an art line. So let's talk about just kind of the process of putting in an art line and what we need to do that. So just some basic supplies. Usually we use a 20 gauge catheter, and these are special catheters. They're a little bit longer, so we want to use a 20 gauge arterial catheter. You need some sort of chlorhexidine or PrEP to cleanse the skin. A 1% lidocaine can be infiltrated around her radial site before we put in the art line, just to ease any pain associated with it. Other things, sterile drapes, gauze, gloves should be gathered, sutures to secure the line. You're going to need a special transducer tubing. Now, this tubing is specific to transduce lines. This is a very stiff, non-compliant tubing. So this is what you need for the line. And ideally you want to use one with a blood conservation. So they might have something that we call a vamp on it, where you can basically draw blood past the point that you would sample for a lab, and then you can push that blood back into the patient to really conserve blood. You'll need a 500 ml bag of saline, a pressure cable to connect to your main monitor. You'll also need a pressure bag, and I'll talk about that in just a second. You'll need a transparent dressing. An arm board can be used. You just have to be careful about position of the arm so that the wrist isn't hyperflexed. You don't want to cause nerve damage. And then finally, tape to secure the tubing to the patient, and then also the arterial line itself. The radial artery is the most commonly used artery for arterial lines. So one of the tests that we'll do prior to insertion of an arterial line is what's called the modified Allen's test. And to do this, what you do is you have the patient clench their fist for 30 seconds. Now, I mean, obviously not every patient's gonna be able to do this, but first you want to palpate the radial and the ulnar artery, and you might make like a little X where those are where you palpate those. You'll have the patient clench their wrist for 30 seconds, and then you want to compress both the radial and the radial and ulnar arteries. So you want to compress those, and then the next thing you'll do is release the ulnar. So when you release the ulnar, what you want to check to see is did the color pink up within about 5 to 7 seconds, indicating that there's adequate flow via the ulnar artery to that hand. So if not, if the hand stays if you don't see return of color, then that's what we call positive Allen's test, which indicates that's not to put a line in that hand. So you might go to the other side and do the Allen's test just to make sure that patient has adequate flow to their hand. So usually that's done by the provider that will be putting the line in, but I wanted to let you know about that. All right, so some other things to think about during setup is you want to prime your transducer tubing. So remember, you're going to be using a very specific non-compliant stiff tubing, and you'll use your saline bag and you'll spike it with this tubing. And then you want to, you want to prime the tubing, but you want to do it under gravity and not with the pressure bag inflated. If you prime your tubing with the pressure bag inflated, you can introduce a lot of microbubbles, which can be they can cause a lot of problems down the road. And then you want to make sure you connect your pressure cable to the monitor and tubing, and I'll kind of show you what that looks like as well. The other thing is during insertion, you might roll up like a bath blanket or a towel, something to kind of hyperflex the patient's wrist to just ease placement of the arterial line. And then once you transduce, so I'm going to use my mouse here, but once you transduce that tubing, what you'll do next is inflate the pressure bag to 300 millimeters of mercury. And this is just kind of another drawing of it. So that's kind of the last step you want to do when getting the tubing ready. And then you want to do a fast flush through the system. So those would be the order. So you want to remove all air from your IV solution. So a lot of times we'll do what we call burping the bag, where you can use like a needle in the port site to push out any air, or you can use a syringe with a needle and pull out any air. You want to fill your drip chamber, flush the tubing, remember under gravity, then pressurize your bag, and then you do a fast flush through the system. So that's the proper way to set up your line. Now, once the line gets inserted, you're going to level your transducer at the phlebostatic axis. And the definition of this changed a number of years ago, but basically the definition is the fourth intercostal space, mid-anterior posterior. So you just kind of want to, from the side, look at their anterior posterior and then fourth intercostal. And usually what I've always done clinically is taken a Sharpie marker and mark the chest where we're leveling the transducer. And I'll just be super honest with you here. Like, one of the things we'll say is, at least if you're off, you're consistently off, right? So if you're all leveling to the same X on the patient's chest, you're not going to get wackadoodle numbers all over the place, versus where if everybody is eyeballing it where they think they should be leveling the transducer. So that's just a strategy. Other things I've done clinically is taken an ECG patch and put it at the phlebostatic axis and put an X on it to say this is where we're all leveling. So there's lots of different ways, but you just want to make sure that you're leveled appropriately. And the thing with a transducer is you can, and you'll note this, when you take that transducer, so once it's hooked to the patient and you move it up and down, there are huge pressure changes. And I always jokingly say, you can take that transducer and make the blood pressure anything you want. So that's why it's important just to be leveled at the phlebostatic axis. Now, you can put the head of bed anywhere from 0 to 60 degrees and still get reproducible numbers. So the patient can be sitting up, and as long as you've got the transducer leveled at the phlebostatic axis, you should be fine. Now, one of the other things that we'll do prior to insertion is we'll zero the patient's, we'll zero the transducer to atmospheric air. And then usually most facilities, they'll have you zero your lines at least once a shift. So I'm not going into detail on how to do that here because it's kind of hard to describe, but just know that you'll have to zero your line usually at least once a shift. So once the line is placed, you really need to make sure that it's secure. So usually we'll put sutures right on the catheter hub itself. So you want to put sutures or some sort of tape, steri strips, but you really want to make sure that line is secure before you place your transparent dressing over the arterial line itself. Now, some other little tidbits to understand is you can easily draw blood gases or any labs from your arterial line. And in this system, you could see here, so the nurse is withdrawing blood or drawing blood from the line, and they're using a VAMP system, but basically it's a blood conservation system. And anytime you draw blood from an arterial line, you have to literally think through, like, which way is that stopcock turned? Because if I have an open line, I don't ever want the stopcock turned away from the patient because the patient can bleed from that line. So you really have to think through the way in which your stopcocks are turned. So like here, they're drawing blood, so the stopcock is turned away from the patient. So the stopcock in this one is like way back up here. With this system, they were actually using a VAMP line. And so basically they withdrew blood from the patient's radial all the way through that line and then clamped it here. And now they're going to draw blood from this point. And then once they're done drawing blood, they'll flush the system and flush all of this blood back into the patient. And this is a means of blood conservation. So now one of the things I need you to pinky swear. So I need you to hold up your pinky and pinky swear and say after me, I will never, ever administer medications through an arterial line. Don't do it. You can't. You can actually cause a limb necrosis, limb damage. Do not administer medications through an arterial line ever. Promise? Okay. All right. So a couple other things. You know, like we always have this debate, like, you know, a lot of people say, oh, we put a cuff on the patient's arm to make sure that the blood, the cuff pressure, the art line pressure match. Okay, let's get something straight. They are not going to match. You have a catheter inside of an artery. Okay, stop there. Now you have a cuff on top of someone's arm that's measuring a pressure through skin, fat, muscle, vessels. You know, they're not going to be the same. And here's a little surprise that everyone's always shocked when I say this. Do you know that your non-invasive, so your oscillometric blood pressure cuffs, so your automatic blood pressure cuffs, they don't measure systole and diastole. Did you know that? It can't hear corticoff sounds. And so when you get a non-invasive blood pressure, it's basically just taking a mean and then it's calculating a systolic, diastolic. Whereas an arterial line is inside of the artery, and I'll give you some specifics of when you should question your art line. But in general, a cuff and art line, the pressure shouldn't be the same. They really shouldn't be the same. Should they trend together? Sure. If one goes up, the other should go. I mean, sure, they should trend together, but they shouldn't be exactly the same. And the other thing is there's so many potential errors with a cuff. Is it the right size? Is it the right width? You know, where's the patient's arm? Was the patient moving? Is the patient's arm above the phlebostatic axis, below the phlebostatic axis? I mean, there's so many things that can cause error with a cuff that if you've got an art line, use your art line. So how do I know I can trust my art line pressures? And the test that we do is called a dynamic flush response, or dynamics, you might hear called square wave test, but these are all the same. So basically what you do is you're with your transducer. So I've got here an ART, CVP, and PA line, but just focus on the ART line, is you're going to either squeeze and fast flush, or some of them might have like a little pulley system on it where you're going to do a super quick, like 1 second fast flush. And what you'll see is the line, basically the value will go up. You should see a plateau, and then you're going to look for oscillatory waves after that fast flush. If you have 1 to 3 oscillatory waves and they're less than 0.12 seconds from each other, then you can trust that line. And that's how we validate whether the numbers are reproducible. So again, this is just kind of showing, this is what an optimal fast flush test or dynamic response test would look like. You do a quick squeeze and flush, you get a plateau, and you should see 1 to 3 oscillatory waves. So in an overdamped line, you're not going to have many oscillatory waves, and that's kind of classic. And usually, I'll talk about when you see this in just a second. Now, an underdamped line, we will often say the catheter has a whip on it. When you do a fast flush, you see multiple oscillatory waves. So those are just a quick way and test that you can do to say, okay, I trust this arterial line. So here was a patient, and I want to give credit to Fiona Winterbottom from New Orleans. She's one of my CNS colleagues who I absolutely love. But this is a patient we were putting together a presentation for NTI, but her patient had a blood pressure art line of 143/40 with a map of 68, but the cuff was reading 102/53. So they did a fast flush test. She had 1 to 3 oscillatory waves, and the duration was less than 0.12 seconds. So in this case, we trusted the art line. So, you really should go with the arterial line and take off the darn cuff. Why are you doing cuff pressures when you have an arterial line? Just asking, like, seriously, cut it out. So if you've got a good dynamics response test, take off your cuff. So an overdamped line, so this is, we'll say that the line is damped, but basically when you do your fast flush, you don't get those oscillatory waves. Your systolic will be erroneously low and the diastolic will be erroneously high. And when you get this, look for air bubbles in your system. Do you have the right tubing? Do you have any loose connections? Maybe your fluid level is low in your pressure bag, so make sure your pressure's at 300 and make sure there's enough fluid in the bag. Or maybe the line's just been in for a long time. An underdamped line, a lot of times we'll say this catheter has a whip on it, and you'll see an artificial spike in the waveform. And in this case, the systolic will be erroneously high, and the diastolic will be erroneously low. And microbubbles are the classic cause of this. Also, if you've got too much tubing on your line, that can be the problem. Or if you have a defective transducer, that could also be the problem. So usually it's either bubbles or tubing are the issue for this. All right, so finally, I want to wrap this up and just remind you that AACN has a lot of references and resources, and they also have, I love their AACN Practice Alert on obtaining accurate non-invasive blood pressure measurements if you only have an oscillometric cuff. So anyway, I just want to thank you again for joining me on episode 6 of this series, and stay safe out there, and episode 7 will be coming soon, where we will talk about vasopressors, vasoconstrictors, vasopressors, I can't even talk, vasopressors, inotropes, and vasodilators. Oh my, so that'll be in the next episode. Thanks again for joining me.